So this is only a 1 hour session and there are quite a few of you, but it'd be really useful for us if you put in the chat who you are and your role and where you work, and potentially what you would like, what you hope that we're going to cover today, and we'll try and make sure that we cover that, and maybe we can stay and do a few Q&As at the end to make sure that we address that. It's always useful to know who our audience is so we can slightly adapt how we're pitching it. Brilliant. So we've got Gemma, who's a PCN pharmacist, and Susanna, who's a paramedic and trainee ACP working in primary care. Brilliant. And there's a bit more about bloods. This is the right session for you to be in, hopefully. Shelley, who's a pharmacist. We've got a physician associate. Brilliant. Got an ST3. Health and wellbeing coach. Paramedic. So it looks like we've got a good range today. Advanced practitioner.
That's mentioned about red flags. That's good. Yeah, we will hopefully cover that as well. Anna has put optimization of consultation and investigation. We'll give an overview today, Anna. So I don't know how much of help, because if you have to remember, we're giving a wider audience, multi-professionals here. So, but I can stay behind a bit if you wanted to ask any specific questions.
We've got advanced nurse practitioner. We've got clinical pharmacist. Brilliant. So does that give us a flavour, Saira?
Yeah.
Of what kind of what, hopefully most of it is in the presentation. But yeah, there's specifics that we haven't answered. Please do stick your hands up if it's quite relevant to the slides at the time, or Saira and I will stay at the end to help you if you've got any muddy points or something that you need clarifying. But you're all most welcome. And if you've got differing viewpoints, challenge us, because actually sometimes, and when we were writing this, we didn't necessarily disagree, but there was like different viewpoints on things. So that is always useful because it's good to see things from different perspectives. Brilliant. So we are going to move on. So did you know tiredness is a common symptom, and 1.5 in 100 people who see their GP practice every year report new tiredness. Is this figure what you'd expect? Is it higher or lower? Have you got the option on Teams to do thumbs up or thumbs down? I'm not sure you do, but Beauty thought it would be higher. Lower, okay. So different people are expecting different things. So higher. So yeah, so for some it might be a shock for it to be at this number, and some you're like not surprised because it's actually lower than you'd expect. Oh, Anita, I don't know, Anita's comment 0%. What's it that you wrote? It's a new phenomenon. I'm not sure. Since I've been in practice, people have often complained about tiredness. So I'm not quite sure about it being a new phenomenon. Saira, any thoughts?
No, I feel like the numbers should be higher. I see loads and loads. I would say, I think one of the most common, well, there's loads of mental health, there's loads of other things, MSK, etc. But yeah, I would say tiredness is quite common sort of presentation.
Brilliant. So there are lots of definitions of what tiredness it is. It's important to stress that it is normal to feel tired sometimes if you've had a bad night's sleep, because you've got things going on at home, or you're worried because you've got a presentation coming up or things like that. It is normal. So what this is focused on is tiredness all the time, despite measures that you would normally perceive as being beneficial, such as a good night's sleep. So where things are optimized, but they're still feeling tired all the time. And often that tiredness is affecting their quality of life. So it's having an impact on their day-to-day life. So that's the key difference. It's not someone that occasionally is feeling tired for a good reason. It's constant tiredness despite measures that is affecting their daily life. So you encounter a tired patient. What other symptoms or what aspects of tiredness might the patient tell you about? So I'm wondering, have a think about patients that you've seen in practice that say they're tired. What are they telling you? No energy for daily activities. Yeah, depressed, can't get to sleep, early morning waking, disturbed sleep, making errors. Yes, low mood, exhausted despite sleep. So yeah, often they're lacking that energy to go and see their friends or go and do some exercise or things that they would normally do. Not being bothered to want to eat, enthusiasm. Yeah, there could be lots of other physical symptoms, joint pain, yeah, BT. So yeah, they could present with a whole kind of range of tiredness symptoms, or the tiredness is impacting on their physical health or their ability to do day-to-day activities and things. And it could be they present to you with something completely different, and they just happen to mention that they're feeling very tired. They don't feel right, and things like this. So this is where I might do a medication review, being a pharmacist, and they go, but actually I've been feeling tired all the time. It's affecting my quality of life. I don't feel motivated to go and do exercise like I used to, and things like that. So that might be how the patient presents to you. So we're going to move on to the causes of tiredness. And there are many, many causes. So it could be related to a physical illness. So kidney disease, cancer, hypothyroidism. It could be psychological illness like depression, anxiety, post-traumatic stress disorder, or it could be lifestyle related. So we're already kind of getting the picture that it could be quite a number of reasons. So it could be they're drinking too much alcohol, they could be using recreational substances, or even things like being shift work and things might be making them feel tired all the time. And not listed actually there is it could be medicine related. So it could be they're on antidepressants, benzodiazepines, opiates, or things that could be causing sedation and making them feel tired all the time. However, it should be noted for those that present with tiredness all the time, in most cases, apparently, according to CKS, there may be no specific cause for the tiredness to be found. So just kind of bear that in mind when you're working through the diagnoses. Now, when you've got that patient in front of you, the most common cause is depression. Is that what you would expect? Yeah. And so it's what impact. So does anyone want to unmute to say what impact, knowing, so when you're processing that patient in front of you, you know that depression is the most common cause, and someone that's telling you they're tired all the time, what impact is that going to have on your practice? Does anyone
I think I thought it would be deficiencies. Yeah, so I think you have to make sure their physical causes are ruled out. But I think it's just the statistics, isn't it, at the moment, that surprisingly how many people, I would say, they don't actually present with, they don't want to talk about mental health sometimes. And they might just say, instead of saying, I've been feeling really low, they just start with, I feel really tired.
Brilliant. So it's aware. So can you do a depression screening? You might want to do a PHQ-2 or a PHQ-9 and maybe look to rule that out, or just check on their suicidal assessment and things like that. So just be aware that is the most likely cause, but again, less than a fifth of those patients that are presenting to you. Right. We're now going to move over to assessment where GPs are much more experienced at. So I'm going to hand over to Saira.
Okay, thank you. So in terms of, so we've just talked about general, so far Sarah has mentioned what tiredness is. you know, and it is one of the really common presentations that we have. But how do you assess is the question. So first of all, you would always take a good history. And I think everything is really about talking. A lot of it is, and we'll go through some of the questions that you may be able to ask, but it should cover quite a lot of things, from physical symptoms to mental health to social history to lifestyle history. I think that will give you a good clue. Yes, examination if it's appropriate, if you feel like, you know, it's within your competence. And then if you feel like, you know, you are able to order some investigations prior for it to be seen by GP, or, you know, some of the management tips that you might be able to be competent in, we'll cover that as well. Okay, so next, please. So first of all, always start with, okay, I always say within the consultation, the first, you know, the golden minute kind of thing, let patients explain to you what they come in with and what their expectations are. But in general, when you start to ask questions, you should always say how long, you know, the duration. Was it a gradual start, or was it suddenly that you felt it? So when did it start? How long has it been there for? Is it getting better? Is it getting worse, or is it staying the same? And how bad is it? You know, how is it affecting their activities of daily living? It really is important when you start asking them. So if they are working, so are you still able to go to work? If they're a student, are you still able to study? You know, and if they're at home, then, you know, what are you able to sort of do your daily activities that you would do? Precipitating factors is like, what might be the trigger? Can you think of anything that may have started you to feel this way? And they may turn around and say, actually, you know, I had this awful viral illness, and since then I've been feeling really tired. Or, you know, I feel like it may be the medicine that I started, and since then I've been really tired. It could be that, or some life event has happened. So again, going into a bit of, you know, why this may have started. So a general history of tiredness, and then you could ask questions that, when you relate them to the causes, then those are some of the questions that might come on. So I would say sleep pattern is really important, because we determined that the tiredness might be normal for people if they're not sleeping well. It could be a sign of a mental health problem, like if they have early morning awakening, or they've got anxiety, so they find it really difficult to fall asleep, or they're sleeping but they keep waking up. It could be that actually their sleep pattern is just not good, and there's someone who gets tired and they come and have a nap and then they're awake all night. So having that sleep pattern is important as well to ask. Weight loss and gain, again, things like thyroid, which we'll talk about later, but can affect the weight as well. And obviously any significant weight loss, which is a red flag, which we'll cover later, is sort of a, you know, bad sign as well. So you do ask about, so how's your appetite been? Have you been eating okay? Have you noticed any changes in your weight? Have you lost any significant amount of weight, or do you think you put on weight? I mean, some people might put on weight, but that might not be anything suggestive, but they might say, oh, you know what, actually I'm trying my best to lose weight, but actually if anything I'm gaining it. Then, as Sarah mentioned, there's lots of medication that can cause it. So, yeah, so it could be that they're taking a sedating antihistamine, you know, and again, I don't expect everyone to know everything about medication, but it may be just putting a little bit, being aware that actually there are mental health medication that can cause people to feel a bit sleepy. There's morphine, there's other, you know, codeine, maybe if they're on a high dose and they've just started, that could cause it. You know, it could be that clear sedatives. But again, just having a little bit of think of, okay, they said it started a month ago. The only basic question might be to ask is, have you started any new medication at that time? Is there something that you've been taking that's different? Next, please. So one of the obviously causes of, you know, tiredness is diabetes as well. So you could ask symptoms like, have you been excessively thirsty? Are you going to toilet either more often or passing huge amounts of urine? Are you waking up at night time to pass urine? And, you know, same with, I think some of you had actually mentioned about falling, I think in the chat it said falling asleep whilst watching TV or something. Again, yeah, you know, if they've got something like obstructive sleep apnea, they may just fall asleep whilst they're, you know, I mean, some of the people would just, if you're tired, might fall asleep anyway, but it's a normal occurrence that they're having a good night's sleep, but they just fall asleep when they are working or watching TV or doing something at rest or stationary. Do you snore at night time? Has anyone ever noticed that you may have stopped breathing for a few seconds? Or, you know, and that's again pointing towards obstructive sleep apnea, which a lot of people, again, not very common, but if people come in and say, I've been really tired and you know what, I'm snoring a lot these days, and that might indicate towards that. So, with women, particularly, if you're thinking that they're presenting with tiredness, some period history might be, again, within your competence, but you could ask, you know, if you're thinking about iron deficiency, most common cause of iron deficiency in young women is heavy periods. So the periods, you know, are your periods really heavy? Do you get clots in your periods? And then with that, you know, again, if there's a thyroid problem, they can, or some hormone problems and things, your periods can become either lighter or irregular or heavy. So maybe a bit of a period menstrual history in women might be helpful as well. So bowel pattern, I think, why is that important? So conditions like, you know, obviously irritable bowel, you know, some of the times anxiety, tiredness, fatigue, that could be linked with it as well. But also, I mean, in terms of the red flags, what you don't want to miss is someone who, elderly, you know, person who's coming with, oh, you know, I'm going to toilet more often, or I don't go very much at all, and they're losing weight at the same time and they're presenting with tiredness. Again, that's a red flag for something like a bowel cancer or something. Okay. Next, please. We've talked about how mental, so you do kind of almost like a systemic review. So you know, you have a presenting complaint, which is tiredness. You've asked history of presenting complaint. You've asked a little bit more about tiredness. How long? You know, is it getting worse? What's your sleep like? How is it affecting your daily activities? Could there be a trigger or a precipitant thing? You know, is there medication? Is there any life event? Anything that's triggered it? Is it getting worse? Is it getting better? And then you go through the system history, which could be, if you wanted to be a bit more thorough, you could ask, you know, think of respiratory symptoms. Have you been having any cough or breathing difficulties, bowels, weight loss, weight gain, skin? Sometimes, you know, you can ask about really dry skin, which can be part of like thyroid. And, you know, you can go through different systems that might be what we call a systems history, which could help with the different causes that might be there. And then you can come to the mental health side of things and then talk about mood, anxiety, recent stresses, and, you know, housing situation, you know, where that comes into the social history, doesn't it? Where do you live alone? Do you live with someone? You know, diet, how's your lifestyle? You know, if they've increased a lot of weight and, you know, they've probably become more sedentary, then they might feel that actually doing any exercise or anything little is causing them to be tired. Obviously alcohol and drug history, and then you do go into past medical history or any chronic condition which are existent. So it may be that they're diabetic already and their diabetes is not very well controlled, so they're feeling more tired. It could be that they've got COPD or asthma. So just a little bit of history of known chronic conditions that are there would be helpful. Next, please. Okay, so I'm going to stop that there a little bit before I move on to the examination. Was there anything in there that wasn't clear, you want me to repeat, or anything that was sort of you didn't expect? Or is there any more questions that you'd be asking as well? Okay, so you've obviously determined the history, and then, you know, you would do the examination based on the presentation. So if you do think actually there is a mental health element going on here, there is, you know, signs of some depression or some anxiety, you could go on to do the questionnaires for it, or book a follow-up appointment to do a questionnaire. I don't know, depending on the time you've got. But most of the systems now do have these templates that are inherent, like whether it's System 1 or EMIS, you can run the templates as well, like PHQ-9, or even if you want to begin with just PHQ-2, or say that's for the depression. JD7 is for the anxiety. So you could use those questionnaire to get a bit more detail into there. And I have actually had patients that are very tired, you can't find any real physical, you know, causes when they're talking to you. You do suspect that there is a bit of mental health, but actually they don't really admit it, and they just think, oh no, there must be some other reason for time. So sometimes I do these scores with them and then say, actually, it is showing that you do have, you know, you are showing signs of depression, you are showing signs of anxiety. So there's a bit more objectivity to it. You know, you can say, okay, this is what the questionnaire is doing. And then we talked about the system examination. So similar with system history, again, you could do your examination, but that's obviously down to your clinical competency or whether you feel comfortable in that. And it may be as simple as doing observations. So doing a heart rate or blood pressure or oxygen levels, that might help a GP or a doctor to kind of like, you know, sort of get some idea as baseline. And it could be, if you're more competent, that you might want to sort of, you know, do a bit more examination. Okay, refer and signpost at this level if you feel actually, you know what, I've done basics, but you know, I don't know if I want to do more. We'll talk about some investigations that you can order anyway in advance. But if you feel like there's something that you're worried about at this stage, refer or signpost. So yeah, next let's cover the red flags, which is the important bits that you don't want to miss. Okay, so next, please. So I'm going to go through them one by one and then see why, you know, there's association of, can you think of why these symptoms might be or signs might be important and why they're red flags. So significant unintentional weight loss. Someone says, I'm suddenly losing weight. I don't know why, you know, and it is, you know, unintentional, because a lot of people want to lose weight these days. So, but you have to ask that as well. If they're saying I'm losing weight, is it intentional or is it unintentional? Cancer, yes, absolutely. So malignancy is the main one that comes to mind, doesn't it? With significant unintentional weight loss, and then. Yeah, so it could be a slight weight loss or, you know, but we're talking about, when we say significant, we're talking about sort of, you know, quite a lot, quite suddenly as well. So in the last month or 2 months, they've suddenly gone down. Whereas something like thyroid or something might be a bit more gradual. Fever, night sweats, any lumps and bumps that you've noticed? Again, anything comes to mind? Any specific cancers or anything that might come to mind? No, it's okay if not. So things like lymphoma or leukemia can present with, you know, yeah, I mean, any cancer you would consider if there is any, you know, fever, night sweats, because they are, but they're also called, you know, B symptoms, which just in lymphoma and leukemias and things like that, particularly people have night sweats and fever. The other thing is TB, tuberculosis, again, not common in this country, but you can get, you know, fever and night sweats with that as well. And then the next bit is a change in bowel habit and blood in stools. So again, that is something, as we mentioned in the assessment, you could ask about, you know, sort of what the bowel's like. Has there been a change in the bowels? And particularly if they're getting blood in the stools, and that's a red flag. A new persistent cough lasting more than 3 weeks or coughing up blood. Now, this bit is according to NICE, anybody who's got a new persistent cough for more than 3 weeks actually needs a chest x-ray. But again, that will vary, because if they've had a very clear viral illness, you know, it can take time to resolve. But if they are a smoker and they're elderly and they've got this new cough and you don't want to take a risk, so again, book an appointment with a GP or order a chest x-ray if you can. Particularly if they're coughing up blood, that's a red flag. So muscle or joint pain, I mean, why would that might be important? Do you think if they're feeling really tired and then they're saying I mean, more than urgent, can you think of some of the possible causes with muscle or joint pains and tiredness presentation? So things like arthritis, isn't it? Inflammatory arthritis and things. Immunological, that's perfect. Yes, so you can get all sorts of like arthritis or, you know, other conditions as well. Fibromyalgia, that's a really good one actually, that you've thought about it with we haven't actually included that in one of the tiredness causes, but it's true. It's true. People can present with being tired and achy all over, and, you know, muscles and generalized aches and pains. There's also vitamin D deficiency, which again, you know, if you're getting tired and you're particularly presenting with joint pains, you know, you might want to request the vitamin D levels as well. So focal neurological symptoms. So obviously we can think of some serious conditions, but also things like vitamin B12 deficiency can present with things like pins and needles or, you know, numbness and things that they're presenting, along with anemia, then again, that could be vitamin B12 deficiency. Recent travel or tick bite, can anyone think of what the reason might be for that? Yeah, perfect. Lyme's disease, thank you. So yeah, brilliant. So that is something also to bear in mind. Okay, any questions so far? Encephalitis, yeah. They'll be the fancy things, you know, that you, yeah, absolutely. But it's also putting, you know, in context of what might be happening. So put it all together. Okay. So what are the possible differences? We already talked about them, but the reason we said about onset is if it's just a sudden onset in the last few weeks or so, and they're just feeling tired and they've got other things going on like cough or viral infections or you know, even throat, anything like that, they will feel tired for a while, you know, and it's more recent and sudden onset. Obviously, like I said, medication, again, if they can pinpoint or you can pinpoint and say, since you've been feeling tired, is there any new medication that you've started either over the counter, you've been taking anything, or is there anything that we've started for you? So other conditions which are underlying, they mostly is a gradual tiredness over time. So liver, kidneys problems, you know, diabetes, thyroid, anemia, all those things, you know, will present gradually. Obviously, we said that depression is a really common cause of tiredness, and although we're not covering that much today, that is, I think, like Sarah mentioned, a very common cause. Always bear in mind. I do say that obviously, if you think you've ruled out sometimes the physical causes, people do sometimes feel better, because I have had patients come to me and say, yeah, it could be my mood, but actually I think there's something else going on. I think I'd really like a blood test, and that's fine. You know, sometimes that reassures them as well, and reassures us that there isn't any physical, you know, thing going on. But if it is obvious symptoms and signs of depression, then obviously we'll go down that route. We talked about obstructive sleep apnea already, but essentially there's something called Epworth scoring system that you might, you know, want to do. You might have seen GPs do that, and essentially that's if they're snoring a lot at night time, they're falling asleep, they have a good night's sleep, they don't know that they've been sort of, you know, snoring so loud. It probably is their partner who's noticing it, that they may be snoring or stopping breathing for a few seconds or whatever. It's usually the partners that notice it. But the most common presentation is they say, I'm just sleeping all the time. I fall asleep on my desk. I fall asleep after lunch. I fall asleep, you know, watching TV, and I'm just falling asleep a lot. And that's something, again, along with, you know, other contexts that you might want to consider. So glandular fever we'll cover in a minute. Lyme disease and chronic fatigue syndrome we'll cover later as well. But Lyme disease, I don't think we'll cover that in much detail. But again, if there is a travel history, they've recently been somewhere, they've got tick bites, and you know, they're presenting with a rash and they're feeling tired, then again, something to consider. Not commonly that they will just present with tiredness. Hopefully they'll present with other things as well. Okay. So let's talk about glandular fever. Younger patients is the population you're considering here, common between 15 and 24 years. And so you wouldn't really see that much in above 40 years, for instance. And the common presentation is sore throat, lymph nodes, so they might notice some lumps in the neck. And you know, I think the important thing to remember here is afterwards they get like a post-viral fatigue. So you know, that's another thing to remember, is that they will feel tired during the illness, which a lot of people will expect that, okay, you're tired because you're unwell, but often 1 in 10 people can present with post-viral fatigue, which can last for several months. And that's, again, going back in the history and looking at, you know, did they have anything like that could be causing it. So yeah, again, I wouldn't expect you to diagnose these things or be, you know, but it's just mindful of these things, that if people are coming with sort of persistent fatigue, they've had all sorts of blood tests, they've had all the mood, you know, everything, and it just, you know, still persistent fatigue is happening. There is a criteria for it though. So chronic fatigue syndrome, or what used to be called ME, is now called CFS more commonly. So the criteria for it is persistent fatigue, but also the significant impairment of their ability to engage with daily activities that cannot be explained by any other illnesses. So like I said, you have to exclude a lot to be able to say that you have CFS. And they have to have these additional factors as well, which is often they get very tired after activities. So they'll say, well, I used to be able to go to gym, I used to be able to walk a lot, but now I can't, you know, every time I do a bit of activity, and I have seen patients with CFS who say, I went to gym, you know, for one day, or I went for a long walk one day, and actually then I just was tired for the next whole week. I could not do anything. But, you know, you have to put it in context as well. Like I said, if there's a constant fatigue. Second feature is post-exertional malaise, which is disproportionate to the activity. So obviously, if you're new to, you know, exercise and you've never been doing it, you will feel tired. But we're talking about disproportionate, you know, exertional sort of malaise, post-exertional malaise. And they often have sleep disturbances, and it starts to affect their ability to concentrate and ability to have cognition. What we'll do is we'll put these links in the chat, Sarah, when we're able to, so that if you wanted to, you know a bit more about it, then you can find out. One thing I would say, even for me to revise for this, it was tiredness and fatigue, CKS, NICE guidelines. 100% it will have all of it, what we've covered today. So if you wanted to ever refer back to, oh, what investigation do I need to do, or what are the guidance, or what symptoms, you know, yeah, that might be something to do. Okay, next, please. So what are the blood tests we're going to do? Okay, so next, please. So you can go on the ICE profile as shown here. There is a guideline on there if you wanted to know. If you just put tired in the search, it does come up with these investigations, but I'll just go through a little bit in there. So if you go to the next slide, please. So according to the NICE CKS guidelines, anyone presenting with tiredness more than 6 weeks should have these blood tests done. Okay, so you'll be ordering full blood count. And ferritin on its own, you can just request that, but you can, if you're suspecting iron deficiencies, you can do iron studies itself. But for basic, you know, that should be enough. Full blood count, ferritin, you can either request glucose or HbA1c, which is for the diabetes screening, liver function test, kidney UNEs, TFT, which is a thyroid function test, and then anti-TGG, which is the celiac screening, and then calcium. Those are your standard, you know, blood tests that you should always consider as the baseline, I would say, when someone presents with tiredness persistent for more than 6 weeks. Next, please. So now we'll go through why we request these and what the significance of this might be. So full blood count, which has hemoglobin, which gives us an indication of either anemia or polycythemia, what that means is, for you to, in basic terms, is that if there is deficiency or low hemoglobin, that's anemia. If it is high, that is polycythemia, which again, you know, it might be difficult for you to interpret, but something that, you know, just if for your information, that these are some of the things that can present. Same with some of the hematological, like cancers and things, can affect the blood count as well. Same with iron. Like I said, if iron is low, you might want to do more iron studies too, or the GP, you know, you could refer to them or physician associate to be able to do more blood tests as well. Next, please. So thyroid function test. Oh, sorry, is that the next one? Yeah. If it's low, the most common cause of tiredness is low thyroid function, which is hypothyroidism. It slows your metabolism as a whole, so people present with that. Overactive thyroid can also present with fatigue as well. So that's why we do the thyroid function test too, for the hypo or hyperthyroidism. So diabetes obviously presents with tiredness, but it obviously also presents with, like we mentioned earlier, excessive thirst or passing huge amounts of urine, volumes of urine. But this is again rare, but if you are concerned, you should, you know, get somebody senior to look at it. But if patient is sort of presenting with something called, you know, fruity pear drop breath, it's a specific sort of breath that they have, and they're excessively, like, they're unwell, you might want to do there and then like a glucose or ketones in the urine if there's signs of that, because there are some complications they can present with as well. Next, please. So kidney function test, which is UNEs, we have to, because the chronic kidney disease can present with tiredness. So, and some of the electrolytes, so sodium, potassium, you know, those things, if they're abnormal, it can also present with these symptoms. And as we know, the reason is kidneys, if they're not working very well, the waste products of the toxin builds up, and you know they can affect the body. Sometimes in renal failure, which again, if the kidney is really off, they may present with anemia as well. Next, please. Liver function test, that's actually an interesting one, and that's why it's included in the screening. I had a patient literally presenting recently who had a abnormal liver function test, and we went on to do a further screening, and he had hepatitis B, and he was very shocked when he came because he had all his symptoms for a year was tiredness, extreme lethargy, he put it down. He was a postman. He put it down to his shift work, and he was like, I just thought I'm working too hard. And now he felt sorry. He was almost a bit upset that he hadn't sought help earlier. So yes, you know, there's multiple causes of liver, but that's why we request liver function test, because one of the earlier symptoms is tired all the time. Okay, next, please. So especially for elderly people, you know, like I said, I've included in the list anyway that calcium is important more than 6 weeks, but it's particularly things like multiple myeloma or some of the other cancers. They can cause a raised calcium, but there's also hormonal, like parathyroid hormone changes, etc., that can cause it as well. So again, just for your information, that's why you would request this. Okay, next. So this is an interesting one that celiac disease actually presents with tiredness as well. And if you've got someone with bowel patterns, and remember we did talk about if someone has change in the bowels or blood, or you know, tummy pain along with the tiredness, it is very important to do this. But the reason it's also included in the screening for more than 6 weeks is sometimes people don't present with the obvious bowel symptoms either. And it is 1 in 100 people that can present with it, and females are more common than men. But the thing I would say, remember, is that if someone is suspecting themselves, a patient might be excluding gluten themselves, because they're like, every time I have gluten, I get bad tummy, I go to toilet alarm, my tummy, I get bloating. So I've been excluding it. So you can't order the celiac test or what is called, if you put it in the profile when you're requesting on ICE, you put TTG, which is what it comes up as celiac screening. So it's TTG, which stands for tissue transglutaminase, but you don't need to necessarily remember that, but TTG is what the celiac screening is. But I was going to say that unless patient is on gluten food for 6 weeks, the test would be like false negative, because you've excluded the diet, so it's not picking up the antibodies against the gluten. So it's really important to ensure that people have been taking that for 6 weeks prior to having the blood requested. Okay, that's the only one. Other bloods you can request it there and then, you know, but if you are suspecting this, then be mindful of that. Okay, next please. Another one is glandular fever, like we mentioned earlier. To request the blood test for this, you have to put EBV, which is the Epstein-Barr virus. So if you just put EBV, it comes up with a serology that you would tick on the blood test. Like I mentioned before, people will present with sore throat, glands in the neck, and especially younger patients that are presenting with that, they're feeling tired. You know, the important thing is, again, yes, it is very common in 15 to 24, thank you. And it's in the 2nd week of illness usually that you would order the bloods. So you wouldn't really do it within the 1st week, because a lot of people can have just normal viral illness as well, can't they? But if it's younger patients and it's 2nd week of illness, same with, as we said, 1 in 10 people carry on having post-viral fatigue. So if someone is presenting with fatigue afterwards, you might want to, again, do the blood test for serology, but later on as well. Okay. Next, please. Anything else? So, like I said, if you've sort of done the basic screening, you know, think, okay, I don't know what is going on there. Obviously, get guidance from senior, but there are certain bloods that can be, indicative. So if you think, there is malignancy, strong suspicion, you can do, or inflammation or infection, strong suspicion, then you can order CRP and ESR. If patient you think that they are malnourished or they have a lot of alcohol and they're feeling tired, and they've got like pins and needles, also you can request vitamin B12 and folic acid. HIV, again, be mindful of, you probably need consent and sort of counselling from the patient before ordering it. But one of the things that can present with that. Vitamin D, like I said earlier, if they've got joint pains and bone pains, so sometimes they don't present with joint, they just present with bone pains, then vitamin D is useful. I wouldn't do it routinely in tiredness because it's very common, as we know, deficiency exists around the board, because we don't get much sunlight. So it probably will be an incidental finding, so you don't need to request it. But if you do think somebody has got bone pains and joint pains, then I would request vitamin D. We mentioned Lyme disease serology. Again, is something, if you're not competent, you don't have to, but if you do feel like they've got rash, tick bites, all that, then we mentioned if somebody's got cough and they, either got blood or anything, or chronic cough, and I think blood in the cough and weight loss is red flag. You won't just order chest x-ray and send them away. Obviously, they might need 2-week wait straight away, so just be mindful of that. Okay, so what are you going to do next? So is there any questions so far about this? Well, we can go through this and then maybe we can take questions and answers at the end. So some of the things that you can do as basic, like I said, is if someone's presenting with quite sort of, it's just a sleep, that they have a bad sleeping pattern and they're getting tired, sleep hygiene is something you can go into detail with. If they have got anxiety and depression, what is the basic support that you're able to give it to them? Lifestyle advice like diet, exercise. Again, some of you are social prescribers, some of you, if you're not, you can refer them to social prescribers for simple mental health support or, diet and exercise. So you would refer to GP if you're unsure and you've done the initial screening. Do they need a referral to specialist? Like I said, if they've got red flags, go to someone senior, say, or do they need 2-week wait? Chronic fatigue, there's an actual chronic fatigue pathway existent in the community, which, again, if they're presenting with, tiredness, which is literally everything else has been excluded, they need to be referred on that pathway. So time for Sarah to do Kahoot quiz, and then we'll take questions and answers. It was a whiz through, wasn't it? Hopefully you were with me.
So hopefully, Sarah, you'll be able to tell me, can you see the Kahoot quiz?
Yes.
So if you all, hopefully on your computer, on your phone, go to Kahoot. You don't need to download the app and put in the pin. This is to kind of, Sarah's gone through a lot of information. So this is just to kind of check and bring together all the knowledge that she's shared with us. So thank you very much for that. I've learnt quite a bit.
No problem.
But it's knowing about your competence, and it might be that you request the bloods, but then say once you've got the results, go to your GP who could do the full history, but you would be assessing for the red flags. Just whilst we wait, and just interestingly, we had a patient within our organisation who I think had some breathing issues and presented with back pain, and it turned out, and tiredness, and it turned out they had like lung cancer. And it was the physio that referred them for a chest x-ray.
Oh, great.
And there was like no kind of
yeah, so that's a really good.
Symptoms were quite vague.
Yeah, like I said, if there's red flag, you probably wouldn't wait. If there's obvious unintentional weight loss, there's obvious cough, blood. But routinely, if they're just presenting with vague symptoms of breathing difficulties and things, yeah, chest x-ray is a really good idea.
So the first question, this is the NATH Tired All the Time quiz, is what is the most common cause of patients presenting of feeling tired all the time? So anemia, depression, chronic fatigue syndrome, or malignancy. Hopefully a nice easy one to start. You've all got that right. So who was the quickest? S. Don't know who that is, but well done, S. Next question. Which of these is unlikely to be a red flag symptom? Weight loss, night sweats, more frequent constipation, or cough after 1 week? I say unlikely because there's never 100%. So yes, the cough after 1 week, it has to be a persistent cough. It could become that. So that's why I say it's less like, I should have put less likely, so apologies. The more frequent constipation was the trick one there, really, because that's a change of bowel habit, which would trigger potentially investigations for bowel cancer. Oh, Gemma, well done. Next question. In what age is glandular fever more prevalent? So that's why I put it in the chat, because it got removed from the slide. Brilliant. So everyone knows that. But it's anyone less than 40.
It was there in the very first, when we were taking history. It was still there. It wasn't in the management, but no, good that you pointed out again.
But if we're thinking of management, if you've got a 55-year-old and they haven't had a sore throat recently, it might be a blood test that you don't want to do because it's less likely. So it's understanding the reasoning behind each blood test request and why you're doing it. So it might be that you don't choose to do that test because of their age and because of their history. Well, Gemma's on fire. True or false? Both low and high thyroid levels can cause fatigue. You've all got that one right. Oh, Annie's on fire now. Which is not a sign of diabetic ketoacidosis? Increased urination, increased thirst, increased hunger, or sweet smelling breath? Brilliant. It's the increased hunger. It's not generally related to diabetic ketoacidosis. And it's important just to be able to recognise the potential of this, because it's definitely something that needs dealing with urgently. Oh, Nat's got the flames now. Next, true or false? It is not essential that breads and things are regularly eaten prior to testing for the IgA tissue transglutaminase. That one's too easy. You've all got that one right. Oh, Susie's winning. That was my bunny. Which condition is not commonly known to cause anemia? So chronic fatigue syndrome, poor diet, chronic kidney disease. Brilliant, you all got that one right. All the others could potentially be linked to anemias. Oh, it's close though. It could be any one of the winners. And then true or false? High calcium levels may indicate malignancies. And this is the last question. So obviously I've made these questions too easy. So here come to the winners.
Oh, I did a good job.
In second, we've got Nat. And then in first, have we got my gold money, Susie?
Yay! Well done, all of you, though. I was saying either the questions are easy or I did a good job at teaching, Sarah.
Yeah, well,
I think they all really did really well, so I'm sure
it was just to bring together all the knowledge to make sure that you've got that understanding in practice, really, because you've got to have that background. I've just realised the music's going on in the background, so
I was going to say, it normally plays with the music, doesn't it? The code when someone wins. Yeah, we can't share that here, but right, is it just learning points and summary, isn't it now?
Yeah.
No problem, Nat. Thank you very much for coming. If you have any questions, please do send us through, or So obviously we said there's multiple causes of it. Depression is the most common cause. Make sure the red flags are the ones to consider. Blood test, again, you know, you can arrange them before clinician reviews, and that will help this team. But if you've got any questions, again, before requesting, then do ask the GP or anybody else senior nurse. Next, please. So yeah, those were the we were talking about. So do you want to put that in the chat as a link so that we can?
Yeah, and I'll put the slides in the chat as well.
Yeah, no problem.
So you've got access and you've got all the
then
links
that's fine. Then they'll have it. Yeah. Okay. Next, please. Yeah. Any questions, please? Do you have any questions? And then I think the next slides are more for if you just share them as well. Grow Knott's primary care app. Hopefully you've all got that. If you haven't, you have to remember it's all together. If you look at the very first line, it says Grow Knott's PC is all together. And then you can download that app on your smartphones, and it gives you a single point access for all our events that happen through NATH, and you can even filter it according to your role. And then the next one is our communication channels that we have. We've got multiple. You can follow us on social medias, and don't sort of forget to subscribe to the newsletter as well. Sorry for my sore throat today. I hope you could hear me, but we're here for the questions. If you've got any.
And we finished on time.
Yeah.
And there will be a feedback survey going out. This is the first time we've run something like this, so let us know if it's been too easy or too hard. If there's any other topics that you want to be covered in the same area, that would be really, really helpful going forward. Thanks all.
Yeah, we'd like to see the feedback, and we do improve things. And do let us know what other topics you might want to see. But thank you so much for coming. Have a lovely afternoon.